All right, you've seen it a million times, right? In the movies, on TV, there's a big accident and boom, out comes the hard backboard. It's like the universal sign for handle with care. But what if I told you that whole iconic image, that thing we all thought was the absolute best practice, is actually pretty outdated? Yeah, we're about to dive into how the science of taking care of spinal injuries has done a complete 180.
I mean, it's the first thing everybody shouts at an accident scene, right? Don't move them. You could paralyze them. For literally decades, that was the golden rule of first aid. If there was even a hint of a spinal injury, that was the immediate command, no questions asked. But is that really the best way to keep someone still? For a long, long time, the answer was a definite yes. The rigid backboard was just standard procedure. But then, medical researchers started actually digging into the evidence. And what they found was, well, it was a pretty huge surprise that was going to completely flip that old protocol on its head.
So to really get why things changed, we've got to be clear on what the goal even is. And here's the thing. It's not about making someone totally, completely immobile. Our bodies just don't work that way. The real goal is something called spinal motion restriction, or SMR for short. So SMR is basically a set of actions all designed to do one main thing: reduce the spine's movement, just enough to protect the spinal cord from getting any more damage during a move. And I want you to really focus on that word, reduce. That is the whole key. It's about limiting the harmful motion, the dangerous twisting or bending, not trying to lock someone down like a statue. Okay, so let's get right to it. Let's tackle the elephant in the room, the long spine board. It's the symbol of spinal care, right? The thing everyone pictures. But it turns out its role has been massively misunderstood and honestly pretty misused for a long time. And look, this isn't just an opinion. This is a statement coming directly from the medical protocols. Just think about it for a second. Lying on a hard, flat piece of plastic is incredibly uncomfortable. And what do people do when they're uncomfortable? They shift, they wiggle, they try to relieve the pressure, and all that fidgeting can actually cause more spinal movement. On top of that, being on a board for too long can cause pressure sores and even make it harder to breathe. This was the big aha moment that drove this whole evidence-based change.
So the spine board has pretty much been officially demoted. It's no longer considered an immobilization device for transport. Its sole purpose now is for extrication. Think of it like a temporary slide, a tool to move someone from a tight space, like a wrecked car, onto the actual surface they'll be transported on. And as soon as that extrication is done, a clock starts ticking. The number one priority is to get the patient off that hardboard and onto something better as quickly and as safely as possible. The board has done its job, and at that point, it's just causing discomfort.
So if the backboard's role has totally changed, what does the modern SMR protocol actually look like in the field? Let's break down what really happens now.
It's really a 4-step process. First, they apply a cervical collar, the neck brace. Second, and this is the big change, the patient is secured flat directly onto the cushioned ambulance stretcher. That stretcher is now the primary SMR device. Third, responders will manually keep the spine's alignment straight during any necessary moves. And fourth, they simply minimize transfers and movements altogether.
So these are the modern tools of the trade. The number one device is the ambulance stretcher itself. Now, for more complex situations, responders might use things like scoop stretchers or vacuum splints. The long, hard board, it's still in the toolkit, but it's reserved specifically for that one job, extrication.
Now, this is a really big deal. It's a non-negotiable rule. For SMR to actually work, the spine has to be in a neutral, inline position, and you can only get that when the patient is lying flat. Period. Trying to apply these techniques while someone is sitting up is just ineffective and, frankly, potentially dangerous. But of course, one size doesn't fit all in medicine. The protocol has special considerations for different patients, and a really important one is for kids.
Here's the thing with little kids. Their heads are proportionally way bigger than their bodies. So if you just lay a small child flat, their head will naturally push their chin down toward their chest, which bends the neck forward. To counteract that, responders place padding under the child's shoulders and torso to lift them up a bit, bringing their spine back into that crucial neutral alignment.
Okay, we've covered a lot of ground here. We've debunked a major myth and laid out the new standard of care. Let's just crystallize this into the most important points for you to remember.
So the crucial points are these. First, the goal is reduction of movement, not total immobilization. Second, the long backboard is a moving tool, not a transport device. Third, today's standard is a collar and the ambulance stretcher itself.
And finally, and this is the insight that changed everything, a comfortable patient is a still patient.
You know, this entire shift happened because medical professionals looked at the evidence and were willing to change a practice that had been accepted for decades. It really makes you wonder, doesn't it? What other things that we take for granted as medical fact today might be completely different tomorrow, all thanks to new research?